away. Don't be wasting time on associate matters and so on today. We shall go to the talk. So, the secretary will be introducing Dr. Anoop Kumar to be the speaker. And I to the desk.
Other senior members of Kannur IMA. Respected Vice President, senior members of Kannur IMA and my dear friends. So I get a pleasure to introduce Anoop Kumar A S to the Kannur IMA. Dr. Anoop is an alumni of Calicut Medical College. 93 admission and MD medical care from Manipal Medical College, and after that, from the he is working as consultant in critical medicine at Baker Memorial Hospital, Calicut. Dr. Anoop's emergency medicine കേരളം മുഴുവൻ ഡോക്ടർ അനൂപിനെ അറിഞ്ഞു തുടങ്ങിയത് നിപ്പ പാൻഡമിക് എപ്പിഡമിക്കിന്റെ സമയത്തായിരുന്നു കോഴിക്കോടുണ്ടായിരുന്നു. ആ സമയത്ത് ഡോക്ടർ അനൂപ് നേതൃത്വം കൊടുത്ത എമർജൻസി മെഡിസിൻ ടീമാണ് നിപ്പയുടെ ഏർലി ഡയഗ്നോസിസും അതിന്റെ തുടർന്നുള്ള നിയന്ത്രണത്തിനൊക്കെ സഹായം ഉണ്ടായത്. ഡോക്ടർ അനൂപിന്റെ ആ സേവനം കേരളം മുഴുവൻ അംഗീകരിച്ചതാണ്. കേരള ഗവൺമെന്റ് ബെസ്റ്റ് ഡോക്ടർ അവാർഡ് നൽകി ഡോക്ടർ അനൂപിനെ ആദരിച്ചതാണ്. കേരള ഗവൺമെന്റിന്റെ കോവിഡ് കൺട്രോൾ എപ്പിഡമിക് സെല്ലിൽ ഡോക്ടർ അനൂപ് കൺസൾട്ടിംഗ് നടത്തുന്നു. ഡോക്ടർ അനൂപിന്റെ സേവനം കണ്ണൂരിലോട്ട് വരികയാണ്. ഡോക്ടർ അനൂപ് ഫ്രൈഡേ സാറ്റർഡേ ജൂനിയർ ഹോസ്പിറ്റലിലും ശ്രീചന്ദ് ഹോസ്പിറ്റലായിട്ട് എമർജൻസി മെഡിസിൻ മാനേജ്മെന്റ് ഉണ്ടായിരിക്കുന്നു. ഒത്തിരി പറഞ്ഞുകൊണ്ട് ഡോക്ടർ അനൂപിനെ ഞാൻ ഇന്നത്തെ സ്പീച്ചിന് വേണ്ടി ക്ഷണിക്കുന്നു.
Good evening, senior members and dear friends, and good evening, the doctors watching the program online as well. I'm really happy to see this much doctors here, even with this much heavy rain. And today we'll be having a basic topic, which is very it's a topic absolutely necessary for any practicing clinicians. So from the MBBS days onwards, we all are prescribing antibiotic, and for many reasons we are prescribing antibiotic. So I'll be just trying to refresh the basics about antibiotic, the spectrum, how to use that. Then we will discuss a few clinical scenarios related to antibiotic use. So why we are worried about the antibiotic use nowadays? You can see this is the death per annum with the different causes projected in 2050. So you can see the road traffic accident, the diarrhea, diabetes, the cancer. So everything is coming in a lesser numbers, and you can see the antimicrobial resistant infection. That is going to be the leading cause of death in human beings by 2050. So if you are not preventing the antibiotic resistance, definitely we may not be having enough drugs to treat infections. So that is a really dangerous situation. So you can see the two the plates here with antibiotic diffusion disc. So one is in 1991. You can see the zone around each disc, which is showing that majority of the antibiotics are sensitive to the bug. But in 2021, you can see only very few antibiotics are sensitive to the bug. So that is the difference. The antibiotic resistance is definitely creeping up. So now we'll see a situation. See, we have an organism which is showing in blue that is sensitive to our antibiotic, and there is another organism in you can see here in orange color which is not sensitive to antibiotic. We are trying to treat this organism with a higher antibiotic, and you can see definitely the sensitive organisms that will be decreasing in number, and main concept in using an antibiotic. So the resistant organisms will select out. So even if you are going to treat an infection or going to treat a patient, thinking that you are going to prevent the infection by meropenem on day one itself, like you are getting a patient with a road traffic accident, it's a very VIP, so you don't want to take any risk, and you are going to treat him with a meropenem on day one itself. So this is the one which is going to happen. There will be very few organisms which are resistant to meropenem, and that will select out, and within few days you will get a sepsis or an infection with an organism which is resistant to meropenem. So you cannot prevent any infection on day one itself. That's a basic concept as clinicians we all should learn. And there are different pathogens, and the WHO has categorized it depending on the priority. I'm not going into all complicated matters. And the organisms also depending on the duration of hospital stay. So, like if the hospital stay is less, you'll be having the organism which is very sensitive, like a streptococcus, etc. Then later on, as the length of stay advances, you'll be getting more resistant gram-negative bugs, and later on you can get even colicin, inherently colicin resistant bugs like Pseudotrochomonas, or you'll be getting organisms like Elizabeth P, etc. So here, how we are going to test the antibiotic sensitivity? There are different methods, as you are aware. We have the previous method where you put a disc and see the size around the disc. So whenever you see like a zone around the disc, previously we all have a feeling that whenever you see a zone around the like antibiotic diffusion disc, that indicates that that bug is sensitive. It is not like that. There are definite guidelines saying that what should be the zonal diameter. So if that zonal diameter exceeds, there are two authorities. One is a European authority called UCAST, and like an American one called CLSI. So every year they will update the guidelines and they will give recommendations on the zonal size. So if that exceeds the recommended size, then only we can see that that is sensitive. And again, if one drug is having a higher zonal diameter, that doesn't mean that that is more sensitive to the bug. And again, you can use an E-strip or you can use a micro dilution technique to see whether the organism is sensitive or not. And there are many basic concepts. So these are the concepts when you are using an antibiotic, like typically ill patients. Like you should think about impact on bacterial resistance, which I've already told. The risk stratification, like you have to see what are the risks involved, or like the risk in the patient. Like the patient has already received an antibiotic, the patient is immunocompromised, patient is having already a long hospital stay. So those are the situations where you have to worry about drug-resistant organism, and you will have to start with parent antibiotic. The combination. So majority of the time we tend to use the combination of antibiotic, thinking that you need one antibiotic to cover for gram-positive, one for gram-negative, and one for anaerobic. That is the usual way we practice. We will see whether we really need those combinations. And again, we all we all were taught, even during our UT days, that whenever you treat a specific combination of antibiotic, we'll come to that later. The drug optimization depending on the many de-escalate, and we are not going to give the antibiotic for long duration nowadays. Even a pneumonia patient on ventilator, you can treat with 5 days duration of antibiotic therapy. And whenever you start an therapy, especially for a septic patient, your mortality also will be high. There are many papers on that, especially the Kumar's paper in 2000, definitely debated later. I'm not going into the complications or the issues with those papers, but always keep in mind if you are not selecting an appropriate antibiotic for initial treatment, the mortality chance in most patients will be high. So what is an inadequate antibiotic therapy? So the antibiotic what you are using may not be covering the pathogen. So what are the pathogen involved in common infections? The dosing may not be adequate. Sometimes we may be using a lower dose of drug, thinking that whenever you use not like that. An adequate tissue penetration. Whenever you use an antibiotic, and again for a infection at a particular site, the whatever antibiotic you are using should have enough concentration in that site. Like if you are getting an infection which is sensitive to aminoglycoside like gentamicin, and you are having a pneumonia, and the culture is showing sensitive to gentamicin, but the aminoglycoside may not get enough concentration in bronchial alveolar fluid, and again that you may not be treating an antibiotic. That antibiotic should be having enough concentration at the site of infection. And combination therapy, when it is indicated, if you are not using, that can also have the treatment failure. This is about the usual dosage of antibiotic, which I am going to discuss in detail. And categories of antibiotic. The 3 ways by which you can use an antibiotic. One is obviously the prophylactic antibiotic. I've already told. Majority of the time when we are using a prophylactic antibiotic to prevent an infection, you may not be involved. But there are certain situations like infective endocarditis prophylaxis, or like a patient with a rheumatic fever for a prophylaxis, etc. You may have to use a prophylactic when you are ventilating for a patient with a cerebral injury. You are electively ventilating to protect the airway. Or a patient with a Guillain-Barré syndrome because of muscle being an antibiotic, you cannot prevent an infection. So those concepts should be very clear. And an empiric antibiotic. So whenever you get a urinary tract infection in an ICU, like especially when the patient is sick, you may be empirically starting a BL-BLI combination, like a beta-lactamase inhibitor combination, like a piperacillin, sulfatam, etc. And there are definitive antibiotics, etc. So there are 3 categories. Either you can use it as a prophylactically, empirically, or a definitive antibiotic based on the culture sensitivity. And there are different antibiotic resistance mechanisms as well. That's a huge topic. I'm skipping that. Now, whenever you use oral antibiotic, especially in an outpatient, can be used orally. That depends on the oral bioavailability. That means if you are giving it through the oral route, the gut should be able to absorb that antibiotic properly. If it is not getting absorbed properly, then there is no use in utilizing those drugs as oral medications. So this is showing the bioavailability here. You can see the drugs with excellent bioavailability. These drugs will be having bioavailability somewhere around 50% alone. So you can see if you are using drugs like amoxicillin, clindamycin, doxycycline, otrimoxazole, linezolid, etc. These drugs are having an excellent bioavailability, and majority of the time you can treat the infections with these drugs. Whenever you use drugs like azithromycin, clarithromycin, etc., their bioavailability may not be as good as other drugs. So you may have to prescribe these drugs in an empty stomach. That's the importance of knowing these, that may not get absorbed through the gut, and you cannot use a vancomycin orally to treat a systemic infection. You may be using an oral vancomycin for treating an organism in the gut, like a CD, like Clostridium difficile. That you can use. But a systemic infection you cannot use with an oral treatment. Very less. So it is very simple. I've already shown that my oral bioavailability. So those are the drugs which we do. So this is again the repetition of the same, like the penicillin, etc., having an excellent bioavailability, and again, cephalosporin is also having an excellent bioavailability. So this is like taking or like taking orally. So initially the antibiotic in a maximum concentration, we call it as a, it is following an absorption phase. Then the drug will be getting eliminated, and gradually the concentration in the serum will reach to kill the organism. So there are two types of antibiotic: concentration dependent antibiotic and a time dependent antibiotic. So in concentration dependent concentration you are achieving. So those drugs should be given as a bolus. The other drugs which are called a time dependent antibiotic, you need maximum time above MIC. Then the sidal effect will be better. So those antibiotics are given as a prolonged infusion, like meropenem, piperacillin, tazobactam. There are different infections. We will see that before we should see about what are the common. Without knowing these basics, we may not be able to choose a proper antibiotic. I think even though this was taught in the microbiology days, even during the clinical days during our undergraduation, this was not stressed. So maybe because of that, our concept of using antibiotic is not very clear. So before that, we should know what are the common gram-positive organisms. In both aerobic organism, we have gram-positive and gram. Staphylococcus and Enterococci. Then the gram-negative organisms, we have Enterobacteriaceae, then Trophomonas, etc. And we have different antibiotics, and that may be covering particular group of organisms. So if you are thinking about infection, and while selecting the antibiotic, that antibiotic should cover those group of organisms. So now we'll start with the penicillin. Suppose if you are using a penicillin, you can see the penicillin is having an excellent anaerobic spectrum. Amoxicillin, then amoxicillin clavulanic acid, piperacillin, tazobactam. All these antibiotics are having an excellent anaerobic spectrum. I will come to that later. And these are also having a good gram-positive cover where Staph aureus, Streptococcus, etc. will be covered. And the drug piperacillin, tazobactam will be having anti-pseudomonal coverage as well, but their gram-negative spectrum will be less. So if you are treating an infection which is usually a gram-positive, or like if you want to prevent such infections in the surgical site, etc., these are the good choice. But whenever you are treating a staph aureus, there are two types of staph aureus: methicillin sensitive and resistant, which we will discuss with few clinical scenarios. Those situations we will have to either use fluoxetine, or if it is a methicillin resistant, we will have to use a vancomycin or linezolid. I think this part is very clear. Now we will move on to cephalosporins. So we have first generation cephalosporin. Then second generation may be cefuroxime. That is a drug which is very commonly used in surgical prophylaxis, especially orthopedic procedures. The first generation antibiotic cephalosporin is there. The cephalosporin is also very sensitive in methicillin sensitive staph aureus, and again, if you don't have a good quality cephalosporin available nowadays because of the price control problems, only generic preparations are available. Then we have the third generation cephalosporin, like ceftriaxone or cefotaxime. Then we have ceftazidime. Then the fourth generation cefepime, and the newer one like ceftaroline, etc. So this is the drugs like cefuroxime, ceftriaxone, etc. has a good coverage against Streptococcus, staph aureus, etc. Meanwhile, the ceftriaxone, ceftazidime, etc. are having a coverage against gram-negative also. So if you want like a surgical prophylaxis, etc., you can go with cefuroxime or cephalosporin. But if you want a slightly wider coverage, both gram-positive coverage is always better with cefuroxime or cephalosporin. So for majority of the surgical prophylaxis, you need only cephalosporin or cefuroxime. So this is again the spectrum. I have put it in a different way. Like I already told, gram positives, gram negatives. Then we have the non-permanents like Acinetobacter, Pseudomonas, Pseudomonas, etc. And we have the atypical organisms. Atypical basically Legionella, Mycoplasma, Pneumonia. So if you want to treat an atypical pneumonia, you will have to use either azithromycin, levofloxacin, or doxycycline. You don't have to use all the three. So majority of the community active pneumonia, that's why we compare like a third generation cephalosporin along with like a macronide antibiotic or a respiratory procurinoids to cover for atypical organisms. And again, the atypical organism previously we were diagnosing atypical pneumonia based on the clinical parameters only or the patient's radiological picture. Nowadays, we have definite. So using those PCR tests, we can pick up Legionella, Mycoplasma, and Chlamydia very easily. And if it is negative, you don't have to continue with azithromycin, levofloxacin, doxycycline, etc. So if you are treating a community acute pneumonia, you have to always come empirically when you are starting an antibiotic. A better choice in our area will be a combination of ceftriaxone with azithromycin or ceftriaxone with erythromycin. Now coming to the quinolones, we have two types of quinolones. One is ciprofloxacin with lesser positive spectrum, and the levofloxacin with a better positive spectrum and having a good and atypical coverage. So if you want to treat an infection like pneumonia or an atypical pneumonia or Stenotrophomonas or skin infections, etc., it is always better to go with levofloxacin, moxifloxacin, etc. The pyelonephritis, the urosepsis, the sexually transmitted disease, etc., you can go with. But if you are treating a respiratory infection, there is no point in using ciprofloxacin in those situations. So this is the community acute pneumonia, which I have already. So majority of the time, the community acute pneumonia is caused by Streptococcus pneumoniae, where your penicillin or amoxicillin, carboxylic acid, or ceftriaxone will be having a very good cover. The ceftriaxone is very less in our area. It is there, but it is very less. So you can very well treat with ceftriaxone. So even if you are seeing a patch in the chest X-ray, or the patient is coming directly from the community, the common organism is Streptococcus, and it is sensitive to ceftriaxone, you can very well initiate the patient on ceftriaxone along with an atypical coverage using azithromycin. So we have even ventilated the patients on ceftriaxone, azithromycin, provided they don't have any significant comorbidities, previous antibiotic, they have not received any broad spectrum antibiotic recently, or without history of previous hospitalization. Then another scenario is intra-abdominal sepsis, like following like an appendicular perforation or like any intestinal obstruction, like perforation, etc. So those situations, again, the common organisms are, you can get an anaerobic organism, you can get a streptococcus, then we use a piperacillin tazobactam or like cephalosporins sulbactam, or even you can even use ceftriaxone. But again, the drug resistance may be a problem in that situation. So the best option in that time may be a combination of beta-lactam with beta-lactamase inhibitor like piperacillin tazobactam. So here you can see, whenever you want an anaerobic coverage, the majority of the time we add in our practice. Whenever we think about an anaerobic infection, we tend to start the patient on metronidazole or clindamycin. Like a patient coming to the ICU, you suspect an aspiration pneumonia, even if the patient is on piperacillin tazobactam, as a clinician, majority of us still initiate on clindamycin for such patients. Same way with piperacillin tazobactam. I'll come to that in detail, but see, like antibiotic like penicillin, amoxiclav, piperacillin tazobactam are having an excellent anaerobic coverage, which is almost equal whenever you suspect an amoebic infection, or like in a patient with a pelvic inflammatory disease, the trichomonas vaginalis cannot be covered with these antibiotics. So those situations you may have to use to treat such infections. Otherwise, an antibiotic is an anaerobic coverage. So this is the spectrum of anaerobic coverage. You can see there are anaerobic gram-negative bacilli like Bacillus fragilis and other gram-negative aerobic organisms. And you can see the sensitivity. This is all sensitive to amoxicillin clavulanic acid, meropenem, and again sensitive to clindamycin, and it is sensitive to other antibiotics as well. So here you see these combinations: amoxicillin clavulanic acid, the meropenem. All these things are having an excellent anaerobic coverage, which is almost equal or even better than clindamycin. So you don't need a clindamycin or metronidazole in such situations. And this is again the other. See the spectrum here, the clindamycin, and you can see other antibiotics like tetracycline. All these are having excellent anaerobic coverage. This is other Streptococcus, etc. Here again, you can see the sensitivity of clindamycin. It is compared with tetracycline and amoxiclav. It's almost equal. So there is no point in comparing two antibiotics in such situations. Now coming to the skin and soft tissue infections, you can have different types of infections. So majority of the time it will be a staphylococcus or streptococcus, which can be treated with like antibiotic like fluoxetine, clindamycin, or like azithromycin, or even the ceftriaxone, which can cover Staphylococcus, Streptococcus, etc. Or cefuroxime is also a good antibiotic. But one thing you have to keep in mind is sometimes you can have a toxin-producing staph, which is called as a PBL toxin. So those are that is a situation where to prevent the toxin production, you may have to use an antibiotic which will prevent the protein synthesis like clindamycin, linezolid, digicycline, rifampicin, etc. So majority of the time, that is to prevent the toxin production, we combine the cephalosporins, etc. with clindamycin. So that is another indication of using clindamycin to prevent the toxin production. So this is regarding the oral antibiotics, which I already told, like amoxicillin is having a cover, etc. Then urinary tract infections. Now coming to infections in our routine practice are very less, but always keep in mind whenever you get Candida growing urine culture or the skin candidiasis, and if the Candida cannot usually produce a pneumonia or a urinary tract infection. So even if you find Candida in symptom, you don't have to start the patient on initial antibiotic. The chances of fungal infections in those patients will be less, but there are many other criteria by which you can think about the possibility, like if the patients are neutropenic for more than 10 days, the patient is already, or if the patient is on steroids for a quite long period, or if CT is suggestive of infections, etc. So those are the situations where you will have to think about fungal infections. Otherwise, you don't have to think about fungal infections. This is another situation where we always misuse the antibiotic. Urine routine. Urine routine is showing cells 10 to 20. So whenever, and bacteria plus plus. So whenever we do 20, we diagnose immediately as a urinary tract infection. That is completely wrong. First of all, we are looking at an high power field. So even if you see someone having a urinary tract infection, should be like majority of the time a numerous pulses should be there. A few pulses in a urinary urine routine sample does not say that the patient is having a UTI. The same way, presence of bacteria also will not tell you that the patient is having a UTI. And first of all, a significant cells. So what are the common pathogens? It's mainly the E. coli and other gram-negative organisms. And we have two types of urinary tract infection. It's a symptomatic urinary tract infection and an asymptomatic bacteriuria. So these two things are different. So even if you get a urine culture showing a bacterial growth, if the patient is completely asymptomatic, you don't have to treat in all the situations. Only if the patient is pregnant or like in a severely immunocompromised patients, you will have to treat that. So what is a symptomatic urinary tract infection? The patient is having a significant urine dysuria, increased frequency, urgent feeling, a suprapubic pain, a fever, chills, nausea, vomiting. These indicates that the patient is having that is the or, and again your culture is going on. That is only situation you have to treat with antibiotic. You don't treat all pustules 5 to 10 or 10 to 20 with antibiotic. This is a very basic like companies. Skin purulent cellulitis or a purulent cellulitis. A non-purulent cellulitis, majority of the time it will be because of a streptococcus infection. And when you have a purulent or abscess-like picture, it may be methicillin sensitive or resistant organisms. Majority of the time, treat it for a longer duration. This is not necessary. When you have an abscess, you have to maintain that. And the classic signs of then again local rising temperature, etc. If you have those, definitely you will get antibiotic, and majority of the time you may not get a positive. And already told Streptococcus and common organisms. But there are other situations like diabetic, fresh out of salt water, immunocompromised patients, surgical site infections, human and animal bites, injection and drug use, etc. When these sort of patients always see as a possibility. So this is another problem. Majority of we will not use any penicillin or any beta-lactam antibiotic such patients. The first thing which we have to understand is majority of the time the antibiotic hypersensitivity is not diagnosed properly, or the penicillin allergy majority of the time is because of some additives in the penicillin. So those group of patients you can very well use other cephalosporins. And to ask some particular questions like what medications and antibiotic, what kind of reaction has occurred, how long ago did the reaction occur? So, which is immediately within a few hours. Then multiple skin lesions can be present. Then the patient can have an angioedema, wheezing, shortness of breath, even anaphylaxis. Anaphylaxis to drugs are also common. Today, I've seen a patient, like the patient was already allergic to proton pump inhibitors, like underwent some suturing following a cut injury in the hand. Unfortunately, the patient did not reveal the surgeon that she is allergic to omeprazole. He, as a routine, along with NSAID, prescribed omeprazole, and within few hours, she developed breathing difficulty, hypotension, rushed to the hospital in Kannur itself, where she was ventilated. And today, like I was called there because they were not able to wean her out from the ventilator, and the echo was showing severe hypokinesia. So whenever the patient is having such anaphylaxis or such stressful situation, there is a condition called stress cardiomyopathy. We call it as Cardiomyopathy, where there will be global hypokinesia. Even the adrenaline what we are using can also have anaphylaxis, so also can have these cardiomyopathy. So you should know what is the dose of adrenaline in those situations. Usually we give 0.5 ml as IM. Previously we were all using subcutaneous adrenaline, but now the recommended drug of choice is 0.5 ml of adrenaline as IM. And if you are giving as an IV, that should be in an ICU situation where all the monitoring is possible. So if you want to give an adrenaline IV in the anaphylaxis, you have to dilute 1 ml of adrenaline in 10 ml, 0.1 milligram in 1 ml, and only 0.1 and only 1 ml. That means 0.1 milligram adrenaline you can use. Even after using a multiple dose of IM adrenaline, if the patient is having hypotension, then you have to use a continuous adrenaline infusion. And why we are IM blood supply to the subcutaneous tissue will be very minimal, and even if you give a subcutaneous adrenaline, the absorption will be very less. So the drug of choice in anaphylaxis is always adrenaline, and steroid has no role in such anaphylaxis. You have to use adrenaline. Penicillin skin testing, it's a standard care to perform skin testing in penicillin allergy, and sometimes even if it is positive, or even if it is negative, like if there is a previous history, etc., there is something called an oral challenge. You can give an oral amoxicillin, etc., and to see whether the patient is having a reaction if the initial skin testing is negative. If the skin testing is positive, there is no point in giving an oral challenge again. And in the ICUs, etc., we can use a from that again you take a 1 ml IV to 10, and 1 cc you can give it as an IV challenge and see whether the patient is having any allergic response, because majority of the time in ICU in a monitored setup rather than the skin testing, we go with the IV testing. Again, bit controversial, but that is routinely practiced. And as I already told, You can use cephalosporin in parasitic allergic patients because the parasitic allergy may not be because of the drug per se. So now coming to the culture and sensitivity report, we have already discussed different scenarios and culture methods. So previously we were all doing the manual culture, and as you know, the manual culture will be having a lesser yield. You may not get a proper report, and the sensitivity and the automated culture. You can see like there will be a separate blood culture bottle, and you should add at least 10 ml of blood to that, and aerobic and anaerobic bottle daily. And you should take both anaerobic and aerobic bottles, even if you are suspecting an aerobic or an anaerobic organism. And usually we take two sets. One set will be one aerobic, one set of culture. Be up to 78 to 80%, which can be increased up to 92% with two sets. And if you are going with 96%, but because of the cost issues, majority of the time we restrict it to two sets of blood culture. So here you get a culture report in your ICU. The patient is growing E. coli. The patient had the culture report what you're getting. So how you choose an antibiotic? So the first thing what you're going to look is ampicillin in an E. coli. So here the ampicillin is resistant. Then you look at ceftriaxone. Ceftriaxone is also resistant. That means the patient is having a beta lactamase production. We call it as an ESBL, extending about the combination of beta lactamase inhibitors like piperacillin tazobactam or cephalosporin sulbactam. So here you can see piperacillin tazobactam and cephalosporin or piperacillin tazobactam. Here again, you should be very careful. Majority of us are having a practice of using very less dose of cephalosporin sulbactam. Whenever you use a cephalosporin sulbactam, adult recommended dose is 3 gram twice daily. Means 2 grams of cephalosporin and 1 gram of sulbactam. There are preparations available in India with 500 milligram of cephalosporin enough for an adult patient, or it is really under dosage, and again that can be treatment failure. So if you are using treating a serious infection, always go for 3 gram twice daily in cephalosporin sulbactam. So this is another culture report. Again, patient came with severe flank pain. The patient was sick, requiring minimal loss of process support, and you have empirically started patient on piperacillin tazobactam, and you send for the culture. How the blood is going today, you are getting the report on third day. So how we are going to, as I already told you, get ampicillin. So ampicillin is resistant. Ceftriaxone is sensitive. That means this is not not a organism which you don't have to continue with even if it is responded to the usage of user therapy, you can very well investigate that. Culture is the sound problem is really worse on discussing about the sensitive drug, where it is sensitive to ceftriaxone. So they will just create antibiotic ceftriaxone. Even if the initial antibiotic is if the organism is sensitive to an antibiotic with lesser spectrum, you can definitely do that. Otherwise, again, the chances of resistance will be or the chances of developing resistance will be more. Now coming to the staff orders, this is the concern report. We are getting a staff orders report. So how we are going to it? It's very easy for that. The first thing we have to look at this point is whether the cephalosporin is sensitive or not. Cephalosporin is three negative ways. That is cephalosporin sensitive. So when it is cephalosporin sensitive, that is again an indirect indicator that it is a methicillin sensitive staff or MSS. And here you can see the concept will show the neosol is sensitive and the backbone is also sensitive. So even if it is sensitive to the neosol backbone also, usually the methicillin sensitive staff is we treat with either processillin, flucloxacillin or cephalosporin. Why? Because there are many data showing that the mortality in MSS bacteria will be high if you treat with an antibiotic like vancomycin or like glycoside. So whenever it is cephalosporin sensitive, try to use either processillin, flucloxacillin or cephalosporin. Again, the processillin and flucloxacillin are not freely available on the generic preparations are available. Now the flucloxacillin preparations are also available. But flox and cephalosporin will have only generic preparation. But majority of the time, the MSS can be treated with those cheap flucloxacillin or cephalosporin. Now, coming to another situation, like a salmonella type, the patient with a suspected enteric fever, you are setting the concept. As you all know, now the overall resistance is very high, and the chloroquine resistance was high before. So we always try to initiate the patient on ceftriaxone. But this is sensitive to ciprofloxacin also. So here you can use that. But still, majority of the time, it is resistant to chemicals. That is why the enteric fever we start treat with ceftriaxone. Like you can treat it, and again you can use a higher dose. 2 gram BD. And again, another thing to always keep in mind is salmonella typhus is a similar organism. That is why you will start with ceftriaxone, the drug to kill these organisms or achieve enough concentration inside the cells will take time. So the reversals or the disappearance of fever will take at least 3 to 4 days. So you have to convince the patient that even if you are treating with a proper antibiotic, the fever will subside only after 3 to 4 days. Sometimes like resistant infection, etc. If it is not to ceftriaxone resistant, if it is not sensitive to ceftriaxone, then we will have to use drugs like IDCCM, where the fever will be slightly earlier. And there are papers that compare comparing ceftriaxone with acetaminophene. This is not usually required. And whenever you treat and fever, you use minimum 14 days. Otherwise, again, the recurrence will be there. That is why after the fever control, you can 6 hours oral fixing. And in another patient, when you use an oral fixing, the dosage is 400 twice a week. So now the 400 milligram preparations are available. If you are having only 1 milligram fixing like vaccine, you have to use 2 tablets twice daily for a total duration of 14 days. So this is the usual another graph that we have some very forward device. You can see it is resistant to majority of the antibiotic, and even modest resistant organisms are there. So that is a very difficult to treat situation. I'm not going to discuss in detail about the treatment options. Now, like I have already discussed the basic concept about the antibiotic. So now I will see the like in our hospital also we have antibiotic stewardship committee which analyzes all the prescriptions and see the rationality of using the antibiotic. So the same way here in Kannur also I was seeing going through prescriptions. So these are really prescription space where I was trying to hear your opinion. So this is a patient, a 35-year-old man without any comorbidities. He developed multiple episodes of loose stools, following which, because of dehydration, he developed hypotension. Then he developed a really he had this 2.3. So he was shifted to the ICU with a hypotension. So basically, a patient without any comorbidities developing fever symptoms, he has taken food from outside. Then on the same day, right, he developing IBS fever, recurrences, followed by multiple episodes of nutrition. A typical history of food poisoning. Then he was dehydrated because of that he was developing hypotension and it reacted inside. So because he is very sick, the physician was seeing the patient was starting on the he wanted to cover for GI infections also. So he was added to this on ciprofloxacin and for the anaerobic coverage better. So is it justifiable or what antibiotics necessary here? Your views? First of all, in hypotension in this situation is because of hypovolemia. So you have to give the volume replacement. That is the first thing you have to do. You will have to give enough antibiotics, so enough IV fluids to see that the patient is having adequate volume replacement. When we say that the preload is adequate, definitely that preload optimization, the patient's urine output will you don't need any antibiotic. And majority of the time, this food poisoning will not require any antibiotic at all. You can very well treat them with IV fluids. In our ICU also, even if the patient is non-hospital symptoms, we treat them with IV fluids alone, provided they are not having previous hospitalization, not proven otherwise, and again not receive any cross-spectrum antibiotic. You don't need any antibiotic at all. And again, even if you want to start an antibiotic, a ceftriaxone is more than enough. And again, if you're starting a ceftriaxone, the ciprofloxacin is not going to give you any additional coverage. And definitely, IDCCM or IDCCM, etc., we usually do not prefer because it will induce more resistance and again resistance. That's why we do not prefer that. So a ceftriaxone 1 gram IV twice daily will be a ceftriaxone 1 gram IV twice daily will be more than enough. And again, and like these amoebic dysentery is very less nowadays. You don't need a metronidazole for anaerobic coverage or amoebic coverage in all those situations. So even if you want to treat, use an antibiotic, ceftriaxone is enough. And majority of the situation, you don't need an antibiotic at all. So this is a second patient, a 60-year-old man. So he is admitted with urosepsis. So he had severe flank pain, numerous muscles in the urine. Ultrasound is showing like the features of pyelonephritis. So the culture report is showing it is resistant to piperacillin tazobactam, and it is cephalosporins sulbactam. It is intermediate sensitive. Meropenem is resistant. Colicin is resistant. So he was initiated on piperacillin tazobactam along with cephalosporins sulbactam, saying that it is intermediate sensitive, we will give a double gram negative coverage by using 2 BL-BLI combination. Again, it is also a complete, I don't know what word to use, but a completely irrational prescription. You cannot use 2 BL-BLI together. And this is probably a culture error. Like it is probably a manual culture, and they may have missed that. You to get such a resistant organism on the initial admission itself is very rare. So you reassess the culture report based on that. You can decide, or like if it is sensitive to a BL-BLI, you initiate on that. But again, whenever it is a carbapenem resistant, we don't treat it with BL-BLI combination. So what I wanted to highlight at this point is a very basic principle that there is no point in combining two drugs with similar spectrum, like a cephalosporins sulbactam with piperacillin tazobactam, or a ceftriaxone with cefotaxime, or a ceftriaxone with nitrofurantoin, etc. So coming to a third patient, a 70-year-old man, he is admitted with a lobar pneumonia. He had severe pneumonia. That is why he was shifted to the ICU. So he was initiated on NIV and he was started on piperacillin tazobactam. Is it the correct prescription or not? Considering his age, very sick status, etc., like thinking that like an advanced stage may be an immunocompromised situation, you are justified in starting a piperacillin tazobactam. But as I already told, atypical coverage should be there. You have to always add you have to add azithromycin or clarithromycin along with that. And if the risk factors are less, you can very well use ceftriaxone. So whatever it may be, he was started on piperacillin tazobactam. He was improving. So next day, the urine routine report has come, which is showing numerous pulses. So the knee-jerk response was to start the patient on nitrofurantoin. Again, the piperacillin tazobactam is having an excellent gram-negative coverage. You don't need an additional nitrofurantoin or an orfloxacin to treat urinary tract infection in those situations. Okay, so these are the very basic things which we should all understand. So this is another patient. These all are real clinical situations. A 68-year-old lady who is a known case of like chronic kidney disease or maintenance hemodialysis. She was doing weekly 2 dialysis. So because of some like family functions, she has skipped 1 dialysis. And in the same day she presented to the emergency department. On the same day night, she presented to the emergency department with severe breathing difficulty. She was hypertensive at that time, so that is why. And again, she was hypoxic, features of a probable pulmonary edema. So she was electively intubated, ventilated, then she was shifted to the ICU. So in the ICU, when we have taken the X-ray, so this is the picture. You have bilateral patches in the chest X-ray. What antibiotic will you initiate in this patient? Any answers? Again, you don't need an antibiotic. This is a clear-cut picture where the patient has skipped the dialysis and the patient is developing a frank pulmonary edema because of fluid overload. The treatment in that situation is to initiate a dialysis and take maximum ultrafiltration possible. So that itself will cure the situation. And like the hypertension in the initial stage and after the intubation developing a slightly lower BP, it is basically because of you are losing that in the initial sympathetic drive happening during the initial pulmonary edema phase. And you don't need a meropenem to treat that patient at all. You don't need an antibiotic at all. You can extubate the patient within 2 days, and antibiotic is not at all indicated as the patient was not having any history of fever or any respiratory infection. So the clinical history taking and the basic steps we have learned during our undergraduate days is very, very important in those clinical situations. Now coming to the last patient, like a 43-year-old man, is a well-known politician in the city. He is coming to the emergency department with a road traffic accident. He is having an open malleolar fracture and he is posted for the surgery. So like the surgeon don't want to take any risks, so that is why he has started on a regime called a triple antibiotic regime. Cephalosporins for gram-positive coverage, the gentamicin for gram-negative coverage, and metronidazole for anaerobic coverage. Again, it is also completely irrational. You need only a cephalosporin in those situations which won't joint infection, which we have already discussed. We are not expecting a gram-negative infection there. Your cephalosporin itself will take cover of the anaerobic infections also. So you don't have to use all these antibiotics in those situations. So this is regarding the risk stratification, which I've already told, like the immunosuppressed patients on immunosuppressive drugs, the previous hospitalization, etc. You have to think about the drug-resistant organisms. Usually the combination drugs are not necessary, but there are some situations where you will have to use a second agents. Like especially when you use a colistin, fosfomycin, etc., you will have to use some like other backbone drugs also. So usually there is a backbone drug along with a secondary agent. So this is only for an empirical treatment initially, especially for pseudomonas and infection, etc. In neutropenic patient, the classic teaching was to add aminoglycoside always. So even if you use an aminoglycoside initially, if the Pseudomonas is sensitive to cephalosporins sulbactam, then again you don't have to continue with aminoglycoside. So because of shortage of time, I'm not going into the details. There are different mechanisms of resistance, and every year the ICMR will release the mechanism of resistance. There are different mechanisms like ESBL, then again the carbapenem resistance. In ESBL also there are different types of ESBL. Then the carbapenem resistance, we have metolobutolactamase. In that also we have different categories, which are not going into the details, but always keep in mind now from the normal culture and sensitivity, which is called as a phenotypic method, we have even moved forward looking at the genotypic mechanism of resistance and selecting the antibiotic appropriately based on that, or with the genotypic with the identification of genotypic mechanism using PCR test, we can pick up the resistance very early in the ICUs, and based on that, we can select the antibiotic appropriately very early. And now there are newer antibiotic like ceftazidime, avibactam, etc., or astrianum, avibactam, etc., which can be used to treat drug-resistant infections. Ceftazidime, avibactam is usually used in drug-resistant Klebsiella. I'm not going into details of all those things. And again, there are different drug resistance markers like KPC, NDM, BEAM, IMP, etc. You can send a pan PCR for these genotypic markers of resistance. So when you have a methicillin resistant gene, that indicate it is a MRSA. When it is a vancomycin resistant gene A or B, that indicates it's a vancomycin resistant enterococcus, okay, not MRSA. Then KPC indicates it's carbapenem resistant. NDM is again indicate carbapenem resistance, etc. So there are different markers by which you can decide whether it is resistant or not. So to conclude, you should have an antibiogram in your hospital, seeing the routine sensitivity. So based on that, you should have an antibiotic policy in your institution, like the patient coming with a community acquired pneumonia, hospital acquired pneumonia, skin and cell tissue tissue infections, and what antibiotic to use for surgical prophylaxis, etc. Appropriate initial antibiotic is always necessary, but you don't have to overtreat those patients. Drug resistance is it's a big threat nowadays. That's why you should have a idea about what is drug resistance and how to overcome that. The duration of antibiotic. Previously, we all were taught that there is something called a minimum course for an antibiotic. As even as school students, we all were taught for a throat pain, if you are taking an antibiotic, you have to use it minimum for 5 days. And before that, if you stop, the chances of developing resistance to that antibiotic is more. So that concept is completely gone. If you are unnecessarily prolonging the antibiotic, that will produce drug resistance. So if you are becoming afebrile with 1 day of antibiotic, you take it for 2 or 3 days. You don't have to continue it for 5 to 7 days. There is nothing like minimum course of antibiotic. That concept is completely out. And again, even for a severe infection like a pneumonia, you need only 5 to 7 days of antibiotic. A prolonged duration of antibiotic is not necessary for majority of the infection, but there are situations like infective endocarditis, etc., or osteomyelitis where you have to use a prolonged infection. The concentration at the site. So what infection you are going to treat and what is the location of the infection is very important. Like if you are treating a cholecystitis, you should use an antibiotic which is having an excellent concentration in the biliary tract, like epiprocillin, tazobactam, etc. The de-escalation, which I have already shown, even if you are initially starting the patient on like an E. coli urosepsis on meropenem, and later on the culture report is showing ceftriaxone sensitive, you should definitely de-escalate the antibiotic to ceftriaxone. So thank you so much. I was trying to give you an overview about antibiotic usage and a few other the clinical situations we come across during our routine practice. Thank you so much.
Thank you very much, sir, for that informative talk. I think there may be a few questions coming up from the audience.
Not sensitive, resistant to all antibiotics.
Sir, that again depends, sir. Like a community, like a patient coming directly from the community. If you are getting a culture report showing that it is resistant to all the drugs, the first of all you have to go and verify if your microbiology lab is correct or not. Majority of the time, our culture report may not be appropriate. You will get a resistant UTI was possible, but that will be a situation where the patient might have received multiple antibiotics or having some anatomical issues with the urinary tract, or patient will be having active for a quite long time. So depending on the organism, then we have to choose the antibiotic. The phosphorus is a good antibiotic substitution, where depending on the organism, we can choose that. That is why if you just see a culture report saying it is resistant and the patient is having an acute EDIC, patient is not having fever or the symptoms which I have already mentioned, you have to treat it upon. Only if the patient is having a symptomatic bacteria, that is normally and again, you not sometimes if the patient is asymptomatic. That is the first mistake what we do. We are always coming. The patient is having a culture, always you get a positive result. You don't have to treat that. Only if the patient is having a symptomatic, you will get that infection, then you will treat it.
At some point, microbiology, that is like sometimes we see that organism that are resistant to whole microorganisms. And most of them will be asked us to test how they have taken specific
Yeah, that's also really important.
most of them, especially using bag, they should take from the bag. And these bags that we food situations, I have seen once they open it, the coverings, and they take directly from the usually they have to clean them, they have to clean the stuff. So I think the specific conditions also clean.
That's a really valid point. That again depending on the situation, but majority of the time, like whatever sensitivity we see, we go along with that. But as I already told, even if it is sensitive, like what side you are going to feel, whether the antibiotic you are going to feel is having enough concentration at that side, all those points are very important. And again, I know, like a medicine resistant, sensitive stuff, you might get a microorganism sensitivity, but you are not using an organism that must say, you will be using a drug like oxygen, etc. So those points should be applied. There is like IDCCM is an expert in those fields, and he has worked in UK. So I think he will be a better person to compare the practice in UK and in India, especially nowadays. I think he's also working in antibiotic stewardship committees in 2-3 hospitals. So the same things that I have come across, you also might see. I think he will be a better person to describe his experience.
Also, I find that the misuse of antibiotics is very hard to see that it is the practicing the diagnostic solution. Really basic. And this one practical point. See, the most commonly asked society is what is the purpose of life? Answer to that is first we have to decide whether then we like that. We like that. Then we decide. For example, so much astrometry, tons of astrometry was used in this whole tons of it. What will happen? See, we are living with 2 kilograms of bacteria inside of it. And there are even 10 times more bacteria than the human cells. So we do not need who is the real creature. You are the bacteria. Are the bacteria or bacteria are the living? That's the thing. So this bacteria plays an important role in preventing IDCCM or so what happens is, if you take a course of antibiotic, the ball is staying for 2 years. At least 2 years to replace this ball. There is one study that is the EDIC. There were 100 patients between 1 to 6 years who had taken antibiotics, especially the Cephalosporins, for cumulative period of 6 days, between 40 to 60 years. Then what is the mortality? They found that if it was above 60 days, cumulative dose, mortality, what the overall percent mortality is higher. Adjusting that, these antibiotics are doing harm. Does not ever become 1.2 to 1.3 compared to the people who taking antibiotics. So antibiotics are going to be harmful. Look at a lot of your data. You can sense these things to see. So many things can learn about. I will take another example. One hospital, some occupations. I am not taking any call from one particular occupation. So I search whether he is operating or he is just but I found that he is doing all the finances and so I found that he is using antibiotics as per the guideline. That is just 1 or 2 days of the process. After he was covered. Even during discharge situation, go just some pain doesn't. It's not the same antibiotic. It is a standard practice. Okay. So the reason is that see the normal skin problem. It is very intact. It gives tremendous protection against super infections. Which happens normal skin problem. If you want to skin problem, you are trouble. You might take treatment. The normal practice is 2 days of approximately approved by insurance companies of years. Suppose you are taking 2 days of approximately, and it produces more inflammatory infections, such as that. Will be the insurance people will agree with this product? So, minimum antibiotics is the key to. And then the time has come up with some antibiotics source program that they came up with so many scores and things and they were able to reduce antibiotics community practice, for example, around 40% without any change in mortality or any hospital. So, message is that first you think whether you prefer antibiotics or not. For example, whether we prefer antibiotics, we should use. Then appropriate can use for the recommended period as far as possible for the guidelines. Thank you.
Only one more point I would like to add. They are getting many H1N1 infection nowadays. At least 6 patients are there in Calicut and 4 patients there in Cardiomyopathy. So especially in this area. So even if the patient is coming with the COVID-19 symptoms, your COVID test is negative. Always think about this H1N1 pneumonia. Now majority of the labs are doing PCR for H1N1. Always send for H1N1 or you can start the patient on so it's very common nowadays. So typically speaking, one family member is having some sort of fever. After 2 days, other family members are also developing. And one obese or diabetic person will become sick and will come to the hospital. There was a reason that from my place to severe myocarditis and died. That's why I is very common nowadays. So even if it is COVID negative, always think about the possibility of H1N1.
Thank you very much, sir. Yeah, can I go
On behalf of the Kannur IMA, I express our sincere thanks to Dr. Anoop Kumar A S for accepting our invitation and delivering an excellent speech on proper antibiotic use. Also, I thank all members of the Kannur IMA who attended this meeting offline and also as online. We had more than 30 members as online attendance here today. And thank you, meeting is adjourned for.